Now I'll talk about a big one. This is pink eye or conjunctivitis. Now this is inflammation of the bulbar or palpebral surface of the eye. There are viral, bacterial, allergic, atopic, and medication-caused conjunctivitis types. About 70% of conjunctivitis in adults is due to a virus, really, like adenovirus, HSV, or varicella. It's spread by direct contact or close proximity for a prolonged period of time, and is considered highly contagious. Classically, symptoms begin in one eye and then go to the other eye. This is called autoinoculation, where we're kind of rubbing one eye and then touching the other. Now, in viral conjunctivitis, symptoms are usually acute onset of redness or injection of the eye with excessive watery discharge. And in bacterial conjunctivitis, which is more common in the pediatric population, this is typically accompanied by thick, purulent discharge where the eyes are kind of glued shut, especially in the morning. And causative agents for this may be Haemophilus influenza, Streptococcus pneumonia, and Staphylococcus aureus. And if severe symptoms develop within about 12 to 24 hours, we may suspect, a gonorrheal infection. And if not treated, this can lead to permanent vision loss. Approximately 75% of patients, I want to say, that have allergic rhinitis may have associated allergic conjunctivitis. And patients may complain of itchiness, can be headache, fatigue, or history of something like hay fever. And this usually occurs simultaneously in both eyes. The conjunctiva will have a boggy appearance as well as the eyelids, maybe some discoloration or erythema, and discharge, if there's any, may be clear or stringy white. Viral conjunctivitis usually lasts 5 to 14 days, and treatment is supportive with things like artificial tears and cool compresses. And if patients are still tearing, or if it's been under a week, then they still should be considered contagious. Now, in bacterial conjunctivitis, topical treatment may not always be necessary, as evidence shows that topical antibiotics are about the same as placebo at 1 week of treatment. So this may lead to some providers choosing for a delay in treatment and to educate patients on the self-limiting nature of the disease, and to start antibiotics only if symptoms don't resolve. Now, high-risk patients are immunocompromised patients that have uncontrolled diabetes or a history of glaucoma surgery, for example. Now, symptoms don't resolve within 7 to 10 days. If history indicates, we may suspect gonorrheal or chlamydial infections or causes, and this requires systemic treatment. And patients with a MRSA infection after a culture and swab should be referred to an ophthalmologist. And if antibiotics are prescribed in high-risk patients or in contact wearers, you may see orders like erythromycin ointment to be applied on the lower eyelid 4 times a day for 5 days. And in non-contact wearers, you might prescribe ofloxacin or ciprofloxacin eye drops. There are 1 to 2 drops per eye, 4 times daily for 5 days. And now, in allergic conjunctivitis, we will first want to identify allergens or possible allergens. And if this doesn't do the job of trying to eliminate those in our life, doesn't do the job, then oral antihistamines such as loratadine or fexofenadine may be helpful in controlling ocular symptoms. And again, with this, we'll first begin with artificial tears and cool compresses to help with these symptoms as well. And of course, removing those contact lenses if we have any. And medications that may be used are NSAIDs or immunomodulators like tacrolimus and corticosteroids. These all may be beneficial, but should just be used under the supervision of an ophthalmologist.